Let's start in French.
So, je parle en français. Donc, je disais.
So I will be speaking French. So as I was saying, welcome everyone and thank you for joining us.
To the interpretation button on the bottom of your screen. My name is Pascal. Je dois rester dans une langue.
No, I have to stick to one language. My name is Pascal. I am from the KNL Knowledge and Learning team of the GFF. And I have the honor of welcoming you to this event, which is set in a series of webinars that we have been organizing with our colleagues, and we're happy to see you again. I will now share the PowerPoint presentation because it is very important that everyone can use this tool. So first of all, I would like to invite you to choose your language.
Say you can choose the interpretation button at the bottom of your screen. Donc voilà, je continue en français.
Back to French. It is very important for you to rename yourself, and there are several ways to do that. You can either click on your name. My microphone just switched off. Just give me 1 second. My microphone just switched off. Can you still hear me? Yes? Okay. Okay, my microphone is off, but apparently you can still hear me. So let me carry on. As I was saying, to rename yourself, you need to select your name and then click rename, or go in the participants list and find your name and click rename yourself. It is very important. I would like to emphasize that it is important for you to include your name, your country, and if you speak English, French, or both, because this will allow us to divide you in groups per country, and if necessary, per language that you speak. And of course, please feel free to use the chat as you have been using already.
Okay, je peux commencer. Donc pour
Claire,
commencer,
can I start? Okay, let's start. It is an honor to give the floor to my colleague Sanem Roder-Dewan. My colleague will officially join you and will explain how things work around here.
Yes, you are.
Hi, Pascal. Hi, everyone. Thank you so much for joining. It's really great to see so many participants, some of whom joined us last time, and many of whom I think are new faces and names. So welcome to everybody. Today, my job right now is to review some of the basics about iKMC for folks who weren't here last time for our initial session with Dr. Rajiv Bal and his colleagues, some of whom have joined us today. So let me share my screen. So I've put together a very basic summary of some of the key elements of mother-baby dyad care. And we're really focusing on this as kind of the umbrella concept. Kangaroo Mother Care is one type of dyad care where we bring mothers and babies together to reap the benefits of the physiologically natural sort of placement of the two together at the time of birth and beyond. So we'll post this summary sheet probably on the GFF site, but we'll let you know so that you can refer to it and use it in your planning. But I think the important points here to start with are that there is really no evidence to support the routine separation of mother and baby after birth. We're accustomed to seeing it, but it's really in and of itself an innovation that was introduced in the 20th century. And many of our low-income countries are actually far ahead of us on this in keeping mother and baby together in the postpartum period. So there's some terms here that I want to clarify. You'll hear skin-to-skin contact, and I want to clarify that that means placing the dried, naked baby prone, so belly to belly, on the mother's chest immediately after birth. And there's evidence to show that just this, and even the healthy infants, has benefits. the big ones that we've been able to study are breastfeeding outcomes. So 24% more likely to breastfeed at 1 to 4 months if they've been placed skin to skin after birth, and also likely to breastfeed for longer, which of course is very important for our health outcomes. So Kangaroo Mother Care is skin-to-skin contact with breastfeeding support and attempts to discharge early from the hospital. And it's also not a new concept. It was first tested several decades ago. I can't remember the exact year. The important study here is a collection of studies, actually, is the 2016 Cochrane Review that showed that KMC in low birth weight infants was associated with many positive outcomes for this incredibly high-risk group, including a 40% reduction in neonatal mortality, 65% reduction in sepsis, 72% reduction in hypothermia, and 88% reduction in hypoglycemia. So these are incredibly significant findings in countries where often neonatal mortality is your leading cause of death, with low birth weight infants being the riskiest of that subgroup. Your summary sheet also has the most current WHO guidelines and a link that you can go to. The guidelines are basically that Kangaroo Mother Care is recommended for the routine care of newborns that are low birth weight, under 2,000 grams. It should be initiated as soon as newborns are clinically stable, and should be continuous if at all possible, and intermittent if necessary from a clinical perspective. So those are the standing guidelines right now, but they are from 2015. They're, I wouldn't say problematic, but there was a need to explore this further because most of our babies die within that first 24 hours of life, and waiting for clinical stability often means that you're missing that really, really high risk period. So most of our babies are dying before conventional Kangaroo Mother Care can even be initiated. So that's where the most current research comes from. It's an attempt to understand what the role of Kangaroo Mother Care is before infants reach clinical stability. And that is what we call immediate Kangaroo Mother Care, iKMC. And our colleagues, Dr. Chelani and Dr. Zaria and Dr. Ball, who you heard from last time, are of course the leaders of that study that was just published in the New England Journal of Medicine. And what that multinational randomized controlled trial showed is that immediate KMC, regardless of clinical status, decreased mortality in low birth weight infants by 25%. Again, this is an incredibly important finding because so many of our babies are dying before clinical stability can be reached. Another important sort of outcome of that trial was the role of sort of infrastructure and clinical flow changes that were necessary in order for immediate KMC to be possible. So mother NICUs, and that means NICUs where the mother rooms in and receives her clinical care within the intensive care unit, were necessary in order to implement the iKMC trial. And you'll hear more about that from our colleagues that have implemented this in the field. And then lastly, I already mentioned the 2015 guidelines are being revised. The KMC guidelines are being revised. We don't know exactly when the new guidelines will be out, but making iKMC and KMC and even skin-to-skin contact possible for our mothers and babies will require changes in how service delivery is provided. So in the models of care, in the operations within facilities, in the infrastructure. But I want to highlight that bringing mom and baby together after birth is potentially a platform for improved care across a variety of services. So providing CPAP, for example, in that environment allows you to have an extra set of eyes on the baby by having mom there. So we're really hopeful that this kind of service delivery change can benefit in multiple ways. So we'll post the summary sheet for folks, and stop here and it over to Dr. Sonia Trika. Over to you, sir.
Thank you, Sanam. Thank you very much. I hope I'm audible and visible, because my internet connection, the screen says, is a little weak. Anyway, I'll just start sharing screen.
Let's try, let's hope.
Why is it that I'm not able to see? I'm sorry, 1 second. Yep.
Just while Sonia's getting the picture up, I just want to introduce her. Good morning, everybody. It's Alison Morgan here, also welcoming you on behalf of the Secretariat. But Sonia was leading the program in Haryana state of India on the care of the small and sick newborn. And so brings the experience. Last time we heard from Rajiv and Dr. Chelani and Dr. Arya about the immediate KMC and what that looks like in study circumstances. And now we wanted to present an example of what that looks like scaled up without all of those study conditions. So it's a real privilege to have Sonia present for us. And I want to add my thanks to that as Sonia. Thanks.
I am so sorry, but there is some glitch. And Pascal, I don't know if you can help me. I'm not able to see the Zoom thing.
Okay, no problem at all.
On my screen. So what do I do here?
I see what you mean. You should see it on the bottom of your screen.
Yeah. So it's there. I click on it. I'm able to see a minimized version of Zoom right now.
Okay.
Sonia, can you see that share screen green button?
Okay. Yes. Now, no. Actually, it had gotten minimized.
Okay,
now
okay.
It's okay. Now it's okay.
Thank you, Dr. Chelani.
Can you can you see this now?
Together we can make it work. Thank you. Yes, it does.
We can see it.
We can see Sonia.
Thank you. So I'm going to be presenting an experience from India on initiating comprehensive and respectful care for small and sick newborns. So the experience is from a state which is called Haryana. It is in the northern part of the country. It has a population of, had a population of more than 25 million according to 2011 census. Two main indicators that we are concerned about in today's webinar are infant mortality and neonatal mortality. And you can see that IMR was 27 per 1,000 live births according to the latest report, and the neonatal mortality contributes to almost 80% of those deaths that happen during the period of infancy, and it's at 22 per 1,000. Haryana also has a dubious and an ironical distinction of having one of those states which have the maximum per capita income, but also it tops in gender inequality. Anyway, amongst children is also pretty high, to the tune of 72%, as you can see. These two graphs show that there has been decline in IMR, which has been steady, but rather slow. So from 48 in 2010 to 27 in 2019. But the neonatal mortality has been, hovering around 22, 23 for quite some time now. So it shows that, the interventions need to happen very, very fast, and they need to be strengthened as far as possible to have a reduction in the IMR. Oops, what happened? Okay. This brings us to an overview of what is happening across the country. So India, in response to the global ENAP, had launched its own newborn action plan way back in September 2014. And as we can see, there are 6 pillars to this action plan, intervention pillars. which basically follow the life cycle approach. So starting from the preconception period in antenatal care to care beyond survival. And states are supposed to, so once this INEP was prepared to circulate it to states, each of these pillars have intervention strategies, activities, tasks, and some evidence-based interventions that the states are supposed to ensure that their facilities follow. And today we'll be talking more about Pillar 5, which concerns with the care of small and sick newborns. Now, what happens in states? That's what I'm going to be presenting now. So today's experience actually had a de novo beginning. It was an initiative that was taken by State Health Systems Resource Center, which I was leading at that point in time. And we started with the program review of NHM's Child Health Division. We started seeing as to, how much of that policy had percolated down and had actually, entered the practice arena. So it started with a desk review interviews with some key informants, and these key informants were mainly those officers who are in the Child Health Division at state headquarters and also at the district headquarters. Followed by field visits, which threw lots of gaps. So we analyzed those gaps, prepared a roadmap, saw where all we had budget available, mainly the budget that was available under quality assurance and quality improvement within my own office was used to make changes later. So let's see what were the program review findings. We saw these 6 pillars, which are basically, those 6 pillars which have been enunciated in the India's Newborn Action Plan. And in Pillar 5, Haryana had responded by having at least one SNCU. SNCU is a special newborn care unit, which is, a secondary tier, place, basically a nursery for the newborns. So at least one SNCU existed in every district, and every district also had 2 to 3 newborn stabilization units, which happen below the district hospital, which are there in the sub-district areas. In total, there were 393 neonatal beds in place in all 22 districts, which would usually have an occupancy of, to the tune of 90%. But then what we saw here was that the care was fragmented. So there wasn't much of integration and convergence between the maternal health division and child health division, even at the state headquarters, and same was the situation at district level. Nutrition also has different people, immunization is another division. So the convergence which is expected, when you're wanting to do something for the category like a newborn, that convergence was found. There was a lot of scope for improvement in that convergence. So this was followed by monitoring and supportive supervision visits to almost all districts, and the teams went to SNCUs in different districts. What were the findings from the field visits? So let me give you one example where I went myself and I saw that on the ground floor within the labor room complex, there was one big hall which had been divided into 3 different portions, and SNCU was actually these 3 different portions. So one part was for the outborn babies, one part was for the inborn babies, and the part in between was basically having some tables and chairs where the doctors and nurses would sit and fill in their case sheets, etc. And there were some other, logistics and support services operating from that middle portion. But then, as I mentioned, it was within the labor room complex. So there was one antenatal ward, then SNCU, then of course the delivery area and the postnatal areas. So lots of people walking in, walking out. And here I was more concerned about the mothers because, the respectful maternity care that we've been talking about was hugely compromised. And at the same time, these very mothers in the postnatal areas had very, very limited access to their sick newborns who were just next door, but they were not able to go and meet. And KMC was just not possible here. Another finding was that the admission into SNCU was pretty liberal. So at many places, what we saw was that cesarean babies were kept inside the SNCU for some time, for some reason, and which resulted in unnecessary separation of these babies who were otherwise very healthy from mothers. And there were many other babies who were suckling well, who were crying, but they were there because some of them needed antibiotics. Some of them were, it was just that the beds were there, so the babies were there, but they were not warranted inside the SNCU if you follow proper criteria. Manual weighing scales were being used in the labor room, so there was clustering of weights around 2.5 kg. So we do know some of them might have been low birth weight, but then they were not categorized as low birth weight. Some of them may have needed admission into the SNCU, but since the digital weighing scales were not used, that may not have been possible. Admission into SNCU was also on the basis of inborn versus outborn. So the inborn area is supposed to be aseptic area. All the babies who are delivered within the facility, in the same facility, are taken into that area. They may have, sepsis or infection, but they are there. But all the babies who are delivered outside, who are referred from other places, they go into the area which is for the outborn babies. So these were the criteria being used. There was also no evidence of any triage happening. So if at night a family brings a baby who has danger signs, the baby would either be admitted inside the SNCU or sent back home, because there's no step down or step up unit existing at that point in time. There were no predefined criteria, as I mentioned. Continuity of care was also a miss, because we just have either SNCUs or homes. There are no neonatal wards or pediatric wards. I'm talking about the secondary tier facilities in Haryana. And discharges were happening directly from the SNCUs. Clearly, family participatory care was not being practiced earlier. Now, what changed and how? Let me first present how. So what did we do after we saw all this in the district hospitals? Now, newborns, this was actually a part of our quality assurance and quality improvement initiative, which we were doing for almost like 500 facilities, primary tier, secondary tier, even tertiary hospitals. But neonates, they don't have any advocates. They cannot advocate for their own rights. They cannot be lodging complaints. They could not be registering protests. So we thought, why not start with SNCUs in the beginning? So we started with sharing these visit reports with pictures, with videos, with the facility managers, the medical superintendents, civil surgeons, the mission director of NHM. So NHM is the National Health Mission, which is a centrally sponsored scheme, and it drives multiple initiatives for different areas, primarily RMNCH+A, but also for communicable and non-communicable diseases, and also with the Secretary Health. Now, it was very necessary for us to get a letter written from the secretary himself and then shared with the civil surgeons, and then we would be able to follow up with those interventions that have been highlighted in the letter. So we drafted a letter, got it signed from the secretary, and this happened very, very fast. We got it sent to all the districts. And we took pediatricians on board, called for a meeting, in which we also involved people from the NHM office, the Child Health Division. And the purpose of this consultation was to find out barriers. This is what that we are supposed to do. Government of India has launched this action plan. Why are we not able to do what we are supposed to do? So what are the barriers? We found out those barriers, and the solutions emerged from within. And these solutions actually were then placed in 3 imaginary buckets. So one group of solutions, for example, is local solutions. So those pediatricians, the hospital managers, they don't even have to consult anybody else. They don't have to take any permissions. They can just launch those immediately. The second is, of course, for which they would need help from the civil surgeons. And the third would be from the state headquarters. So State Health Systems Resource Center facilitated all 3. And next, because there was a demand for structural modifications. The example that I gave you, where on the ground floor within the labor room complex, everything was happening, we needed to take the SNCU out of the labor room to another area. And what we found was that on the first floor, there was huge area available, but it was all locked. And there were some stores over there. We had to take these stores out and get the SNCU moved to that place. And before moving, we needed to have some structural alterations. So we had to rope in the engineering department and the architecture department for preparation of plans and drawings, and then have budget estimates sent from them to us and arrange budgets. The next, of course, was adaptation of some SOPs and writing of some new protocols and organizing trainings. What changed? So as you can see, one important thing that needed to happen was streamlining the patient flow. We needed to have a reception area, for example, to have, for mothers and families to bring in babies and wait while the doctor examined the baby. We needed to have an observation bed, preferably also a place, or a bed for the mother in case she needs to, to just relax while the baby is being examined and observed by the doctors. Very important thing that needed to happen in all our hospitals was no separation policy. So we got that introduced. Mindsets, as you would expect, needed some time because doctors and nurses were worried that if we have mothers coming inside the SNCUs, there would be higher risk of infection, for example, or some other problems. That the babies could be taken by another mother. So there were lots of issues here which took time, and we needed to also have some more, systems in place. For example, cameras, infrastructure changes were brought in. We needed to get washrooms, shower cubicles for mothers, because if they're there inside, they need to, have basic services, basic amenities for them. Important thing that happened was quality standards introduction. So we prepared some standards. In fact, National Quality Assurance Program does have those. We just needed to adapt some of those, and we created a few more new standards for ourselves. And for those, trainings were given to senior doctors, nurses, quality manager, along with the trained staff would visit regularly. Because what was happening earlier was that nobody was going inside the SNCU. It was only the pediatrician's job. Another thing that I want to say here is that in Haryana, at secondary tier, which is the district hospital, there's just one pediatrician at most places who is complemented by 3 medical officers at the most. So the SNCU is primarily their domain. And there's some nurses are also deficient, but very little staff, and they're supposed to run it 24/7, 365 days. Now, evidence-based clinical care was initiated. Some flow charts were prepared and they were pasted inside the clinical areas to make it simpler for new people in case they're not aware of the standard protocols inside of the facility. What changed? Additional things that happened was having more hand wash stations for the nurses, for doctors, for mothers. Mothers were trained on hand washing, which was, we prepared some videos which were shown to all mothers. They were trained on KMC, on breastfeeding, infection prevention, and also on identification of danger signs in the newborns. Family participatory care, which is a new intervention, staff got trained on that also. And in all SNCUs, step-down units were also provided, and Kangaroo Mother Care was scaled up in all SNCUs over there. So we started with one district hospital, but it expanded to more within a short span of time. So I'm just going to take you through, specific interventions that we did. As I mentioned, the first thing was no separation policy, and mothers now were mandated to stay with neonates. And 2 step-down units, in fact, in every SNCU were created. And it's only in those circumstances where baby is very, very sick that the mother's not allowed. And mother can, in that case, also visit the baby at regular intervals. Once the neonates from inside the SNCU show signs of recovery, mothers are brought in and babies are shifted along with the mothers into the step-down units. Triage, which I mentioned, was not existing earlier. So we created a space for triage inside the SNCU, and pre-evaluation of all sick newborns who are brought, whether it's daytime or nighttime, would be done here by the doctor on duty, and nurse would also do some counseling for the mothers here in this area. We created a standardized flow on a triage categorization system to ensure unidirectional flow so that we do not mix clean and dirty. So that was also followed here. what categorization? So, some structural modifications, as I mentioned, they were done. And what were the areas that were very, very important for us? These were triage area, observation area, step down units, 1, 2, the septic room, the aseptic room. And then, of course, you also need some support areas like changing room, the hand washing area, breastfeeding area, clean utility, drugstore, medicines for keeping medicines, kitchen, and clean utility, dirty utility, laundry, etc. So these areas were demarcated, but our clinical areas, which have been written in bold and underlined, these were the most important, and we ensured that a unidirectional flow was followed here. Now, let me show you some pictures from Kethel. So this, for example, when you start, there's a triage area. Bed for the mother has been intentionally kept by the pediatrician on duty because he felt that it was needed. Those admission and discharge criteria are pasted out there. There's a step down unit where mothers can be comfortably kept. Phototherapy and the open care unit is also kept over there. There's an aseptic. So like I mentioned, there was categorization inborn, outborn, but here now we follow aseptic and septic, and there are criteria for those. And then a drugstore. And this, as you can see, this is the diagram of what happens. So after the baby is received and triaged, the baby would either get admitted into step down unit or aseptic or septic. So whatever is the situation, that is followed. But as I mentioned, no separation as far as possible. Admission, discharge.
Dr. Sonia, is it possible, do you think, to wrap up in 1 minute? That would be ideal.
Okay, sure.
Thank you so much.
I'm not going to be elaborating much on every slide now onwards. So admission and discharge criteria were defined, SOPs and clinical protocols developed. So these were the admission criteria which the pediatricians debated on. We sat with them, and this is what we decided on. So these were then shared with all the SNCUs. And here the important thing is that all babies in step down units who are admitted, they will be admitted along with their mothers, and Kangaroo Mother Care would be ensured for each of these newborns. So in District Hospital Sonipat, for example, this is a picture where for triage, the usual thing that they follow, the color coding, red, yellow, green, that was followed. So red is the aseptic area, yellow is aseptic, and green is the step down unit. These are some pictures where the infection control nurse is taking sessions for mothers on hand hygiene, PPE donning, involving mothers in the care of their babies. So here the mothers, after wearing the PPE required, they go and spend time with the babies inside the SNCUs also. What was the outcome? So generally, because we still have to, COVID happened, the footfall reduced to some extent, and the indicators now need to be evaluated, analyzed, and then we'll be able to, objectively say as to what has changed. But in general, and the quality indicators that we captured, the satisfaction level of mothers, family members, and also of staff have tremendously increased. And the infection rates have dipped. The stay inside the hospitals has shortened. The follow-up has improved. And there is early admission. So the danger signs, because the mothers and family members are now oriented on early reporting of babies with danger signs. So that has started happening. So overall, it has been a very good experience, but we need to analyze, more objectively and present more this time. Thank you very much.
Thank you so much. Thank you, Dr. Sonia. Loads of content, a lot of things to absorb from you. But we're going to take the time to unpack this, and we'd like to invite you. That's why I insisted so much. If you could rename yourselves and add your countries, because we're going to give you the opportunity to have a discussion on a tool that we call a Padlet. It's a tool that is fairly easy to use. It allows you to send your notes, and I'm just sharing the link just now. So this is called the Padlet. I'm going to open and share my screen. So if it's okay with you all, I invite you to open the Padlet. I'm opening it myself in my screen so that I can do this. And so I give you 1 second for all of you to use the Padlet. And as you can see on my screen, there is a test zone. And then there are the questions for the group. So I'm going to put you in groups in a few minutes, but the idea is just to start with to practice the tool. The idea is you're going to double click. I'm just double click anywhere in the document. So if you double click here, it will appear here. If you double click here, it will appear here. So here, and I'm going to ask you all to take 1 minute just to write what would be your motto in life. And then, for instance, mine is, voilà, you don't need excuses to forgive. So I put my name, I could put my country, which is not a country, it's a team. And you could put it like that. And this way you can see, and as you can see, you can move it in different parts. So somebody started, I really appreciated that. So please go ahead. Alison has added be kind. Thank you very much. Anyone else? We just want to practice the tool so that when we go in groups, it's very easy for you to then be able to use it and fill in the little, I don't know, group here to, I don't know how it's called, a map or a map of where you can put all your comments. So I'm waiting for more. So here again, very easily, you double click. Pascal, you put your name, you put your country, and you say something incredible, and you publish. Luis added, I wish I'd have a motto. Indeed. Anyone else? It's really just to practice. So for those who have their screen open, hopefully in each group, there will be one person who will have the possibility to do that. So Hasina, for instance, just added Merci Pascal. I hope Merci Pascal is not your motto. Michael says laugh often. Rovimbo from Zimbabwe adds Carpe Diem. And as you can see, I can very easily move them. Hema added stay focused and smile often. Indeed. And Salam, no regrets. I'm waiting for other people, just a few more people, just for us to be sure that you have the possibility to use the tool when we will start the groups. And I'm going to very quickly check something. Okay. Belise Ngum from Cameroon, happiness all the time. Excellent. It's from Zambia, glad to be here from Mary. Okay, so I don't see the names anymore, but are there more people who'd like to paste? I don't know. Ibrahima, Jean, Joséphine, do not hesitate to use it. Voilà, Faustin, je déteste l'injustice. In French, I hate injustice. We can start seeing. Motto is devise. As you can see on the top screen, motto in French is devise. Voilà. Excellent. Thank you, Mariam, who says she's happy to participate. All right. Thank you very much, everyone. It was just first step for you to get into the groups. I will organize the groups and send you in groups in a few minutes. And I'm just checking how many groups we have. 1, 2, 3. And I'm going to give you a minute. And Alison, would you be so kind and read the titles of the different questions? Maybe you can go through the questions with us that we'll ask you to do in the groups.
Yeah, thanks, Pascal. And thanks, everyone. I hope this is a helpful way. The real purpose of this today's webinar is to really start to articulate and gather together the implementation challenges of both immediate KMC that we heard about in the last webinar, but also more broadly, the challenge that Sonia just presented to us around how do we set up our special care nursery units to minimize separation of the mother and baby, to keep the baby and the mother together. And so what we really want to understand from you is that in your setting, what's the readiness for providing low birth weight babies. In some countries, there's still a mindset that that's the next step. We're prioritizing essential newborn care rather than the care of the small and sick newborn. But as we heard last webinar, 70% of the neonatal deaths that occur are in low birth weight babies. So if we don't address this population, we won't achieve the SDGs. So what's the readiness in your country would be the first question to answer. Then the second one is, what are the constraints and the enablers? There might be a really great opportunity happening in your setting. What are the health system implementation enablers and what are the constraints in your country? And then what supports would you need to either build on those enablers or to address the constraints? So this exercise is a really information gathering. As a part of the GFF Secretariat, we're really keen to support countries where we can to scale up the care of the small and sick newborn, as is the World Bank in general with Sonen's unit. So this will help us to identify, which countries and what sort of priorities you see or where the opportunities are. So this is a fact-finding mission, and we'd love you in your small groups to brainstorm these 3 questions and just throw out ideas that we can follow up with afterwards. Are there any questions, or is that clear to everybody about what we're hoping to achieve? We'll give you 15-20 minutes in the groups, and then we'll come back and discuss. And we've got a few people who have experience. We've got our Indian presenters, Dr. Chelani from last time. We have Michael Mateki Fisher, who's been involved in some innovations programs in Ethiopia and Kenya around the care of the small and sick newborn. So we'll have a look at what you have written and also get some of the responses and ideas from our key informants that we have with us. Thanks. Back to you, Pascal, unless there are any questions for anybody.
I'm not seeing any, in case I'm just switching. Okay. So is it clear for everyone? Dr. Shenani raised his hand. No, it was just all right. Thank you very much. So
no, I just wanted to say
yes,
that
yes,
in continuation to Alison, that we are also in the process of making the toolkit so that the infrastructure, the processes, and what is the collaboration which is required and the challenges. So that is the basic objective, Alison, and Pascal, you rightly mentioned. So those are the things if we will discuss in the group actually.
Yes,
fortunately, Sona is also here. Yeah.
Perfect. Thank you.
And
yeah.
we'll have a bit of time. So
Dr. Arya,
thank you so much. I'm opening the room. Some of you, I might not be allocated to a room. Please, as soon as you can, tell me which group you want to go to. We have 7 groups at this stage, and I've tried to mix some countries. So there are some countries that work together that can share. So you have around 20 minutes. So let me open the rooms and let me know if you need any support. And please do just click on the button you see. And of course, you might want to facilitate the conversations. You might want to take the lead in order to make things happen. Thank you very much. See you in a maximum 20 minutes. So. All right, I'm trying to assign the last people because some people disconnect and reconnect. So I'm just assigning the last one. Boubacar Silla, I don't know where to assign you, so I'm just going to put you in the French group. Munirat used to be Nigerian. Okay. Okay, so people are joining. Okay.
There's still quite a few unassigned, I think, Pascal. You're on mute, Pascal, I think.
Thank you. I was saying that I was just moving a few people because as we've seen some people leave.
Agree. Hello.
J'arrive. Yeah, sorry, Munira, please go ahead. Munira?
Yeah, I just rejoined again. So can you move me to a group?
Oh, okay.
Pascal, it's still about 20 people not assigned to a group yet.
No, people. This means people who didn't, who disappeared, basically. No, that's
Sorry, Pascal, can I also be in the group? But I was unable, I'm finding difficult to go to any group.
Okay,
Maybe.
let me try.
Sorry, to bother you.
No problem at all. Not at all. Alors, Dr. Celani. I don't find you. Oh, you're in the group.
So it's HC.
No, I know. I just, he doesn't appear in the list of unassigned people. Can you go to the bottom of your screen and you should see something called Breakout Rooms.
Yes.
And if you click on the button, you should be able to go to a group.
It's coming, join Breakout Room.
Yes, please.
Okay.
Thank you.
Pascal,
Yes, Hannah.
Dr. Chelani is assigned to room number 5, but there is nobody there in that
Thank
room.
you. 5? I have
Yeah.
Dilsera,
Okay, now
Munira.
Fran is there.
Yeah.
Okay,
Thank you.
Fran is there.
Group 5. Oh, sorry, I saw there are two 5s. I'm moving him to groups. I'm moving them both to the group with Ethiopia.
Okay.
It's a bit strange, but
So the 20 people there have been assigned, but there might be, they haven't clicked to go into their room. Is that right?
Yes, Alison, because the status says not joined. So they must have received they must have received the invitation to join, and they haven't clicked, so it has disappeared from their screen.
Right. Okay. No, that's fine. So there's 5 groups. Is that right?
I was just going to say that for all here in this room, if you can hear us, you may have gotten an invitation to go to a breakout room. If you missed it at that stage, you can always go to the bottom of your screen, and you will find a button with indications of a breakout group, and you can follow that invitation to join a group. And if you can't do that, just speak up, and Pascal will assign you a group, please.
I just want to help one group.
Thanks, Pascal. So yeah, nothing's coming up yet on the Padlet, but I guess people will be talking first before they start writing it up.
So let me know if you want more time to the groups. So we have half an hour now, right?
Yes, and I need about 5 minutes at the end, or 3 minutes at the end, really. So I think
I see.
and it would be good to, I mean, people will be able to see themselves the Padlet and the discussion, but it'd be good to give a bit of time for Dr. Chelani to respond, for Michael to respond, for Sonia to respond.
Perfect.
Yeah, so 15 minutes. So if we come back at 22 or 17 minutes too, so in about 10 minutes time, would that?
Perfect.
No, is that right? 15 minutes. Yeah.
10 minutes is 38. I'm just sending a 10 minutes message.
42. If we come back at 8:42, or whatever that is, we're in Paris. Yeah, sorry. And then we'll have 15 minutes to sort of give a bit of a response and then wrap up with the last 3 slides. I wonder if we need to drop into the group and just encourage them to start putting ideas in, or should we leave it another 5 minutes?
Pascal, there are several people still here in this main room. I wonder if we can just.
Yes, indeed. They are invited to groups. I don't know if they have the difficulty to join, but if they need some help, I'm more than happy to. So Ibrahima, Ndiaouba, Emidiaouba, Joséphine Anne, Fanen, if you need any help, si vous avez besoin d'aide, je suis à votre disposition.
Pascal, perhaps we can just use this as a group and hear from those who
If they would like, I would be more than happy, but would anyone like to open their mics and let us know if you can hear us, or if you're maybe busy doing something else, which is totally fine, but because we know we're very busy.
I'm happy to put ideas in the Padlet if anybody wants to start with their thoughts. What is the readiness to provide care for low birth weight babies in your countries? I see a UNICEF colleague from Cameroon. Any thoughts? Is Cameroon ready to do this, to provide high quality care for our low birth weight babies? I can't tell if anybody is in this room.
Yeah, I think they've all been assigned to a group, but it probably have other work happening, or so that they're
If you're looking to be in a group and you haven't been able to move over, speak up now.
and as Louis said, there is a breakout room button at the bottom if you haven't found your room, and you can click on that to go to a room now. Pascal, just having a quick look at what's been written. Can you help me? The two French responses.
You lose Pascal? Inez, your audio is quite poor.
Hi, this is Ines. Hello. Are you in breakout room? My audio is not working.
Oh, that's better. Pascal, could you kindly put my colleague Inez into the, do you have any Ivoirian room?
In an English-speaking room, I guess?
No, French.
French-speaking, pardon. Yes, I can do that. Yes. Assign. Yes, assign.
Merci beaucoup. Merci, Pascal.
Pas de problème. Voilà, c'est fait. Il faut après, normal, si ce n'est pas le cas, si ce n'est pas possible, regardez en bas à droite, vous avez les boutons Breakout Rooms au groupe, je ne sais plus comment c'est en français. Vous devez cliquer dessus et il va vous inviter à rejoindre votre groupe. Voilà, c'est fait. So maybe RCA is saying that there's a support from UNICEF for the training and equipment of care units. Madagascar is saying only one hospital that used the Kangaroo method in the capital. And what is the name of this baby thingies? Baby care units are almost non-existent.
Thank you.
So we said a few more minutes.
So group 3, are they struggling? They've not written anything down, I wonder.
Group 3, it's Guinea, Central Africa, and I don't know the last one.
Oh, that looks like a group 3. Do you see that? Oh.
I'm sending a message to everyone, thanking them for the contribution and inviting them to continue.
Which countries are in which groups? Do you have a sense of that, Pascal? I'm just looking at group 4. I'm just wondering, group 5 have nominated, they've got Zimbabwe and Ethiopia, but I'm just wondering about group 4. Do you know who's represented there?
Group 4, I have Kenya, I have Cambodia, and I have Nigeria.
Great.
And another person, and 2 people, I don't know which country they are from.
Great.
So what I did is I tried to first create the country groups, then starting to mix them. But then as some people left, I had to reconvene.
No, a nightmare to do. Yeah.
It was fun
So,
in the background.
Pascal, that's helpful. So group 5 is Zimbabwe and Ethiopia.
Yeah, let me write it down.
I'm just adding little notes here.
Great, great.
Oh, you're putting it on there. That's great.
Group
Thanks.
1 is Côte d'Ivoire, Cameroon, and DRC, with quite a 4 or 5 people from Côte d'Ivoire. Group 2 is Burkina and Madagascar, with 4 people from Madagascar, I think.
Wow.
Group 3 is Guinea and Guinea-Conakry and Central African Republic. Group 4, Kenya, Cambodia, Nigeria.
Hold on, slow down. Group 3.
Group 3,
Guinea.
Guinea and Guinea-Conakry and Central African Republic. Group 4, Kenya, Cambodia, Nigeria.
Got it.
And group 5, Ethiopia, Zimbabwe, and Zambia. And Dr. Chidani, and somebody from the results team. And another person, a non-identified person.
Ooh, a spy.
Got this weird thing. I think if I don't turn my computer off at night, it gets cross with me. So the clock is now 5 minutes past. It's really disconcerting.
That's strange.
I know it's happened before. Some little glitch.
When are we coming back?
In 4 minutes, I think. Is that right?
Are you sure?
Is it 4 or 9 minutes?
Yeah. Who knows?
Hi, Michael.
Hi, Saddam. How are you?
Well, according to my clock, actually, it should have been 2 minutes ago.
Shall we send the 2 minutes?
Pascal, this is Aissatou Jack.
Pardon?
So yeah, Aissatou, I don't know whether we know each other, but you know, I'm in the South Asia region after 16 years in Africa. So I'm a long-term bank senior health specialist, and I just wanted to tell you your session is excellent. I tend to work more on pharmaceutical issues these days, but I joined it because it was just so passionate. I'm passionate of mother and child health, so yeah. So so congratulations to all of you who are initiating this.
Thank you very much.
Yeah. And sorry that I couldn't join the group work. I was in another meeting with my real boss. So we had the procurement supply chain, follow-up group every Monday morning. It was Tuesday morning, so I was joining that. So with congratulations, really. Yeah.
Thank you so much. I think Alison, Sanam, Dr. Sonia are blushing in the side, so they don't reply, but I'm sure they're happy. Exactly. Thank you, Sanam, for exemplifying what blushing means. Thank you so much. I'm not seeing Dr. Sonia. Is she, Sanam, Alison, I think she might have been disconnected.
Hopefully, yeah. It sounded from what she said that her internet was playing up, but I'm glad it lasted through her presentation. That was good. Hopefully she'll rejoin.
Okay. I'll be closing the groups in a couple of minutes, couple of seconds. Let me close. on va juste attendre 1 minute, le temps que tout le monde nous rejoigne. Jean Anouan, bienvenue. Inès Ongenda, bien sûr. Jean Morin, Série. Et je crois qu'on va avoir quelques personnes.
Excusez-moi, j'ai fait une fausse manipulation. Je suis sorti de la salle.
Ça arrive, ça arrive. Nous sommes en train de clôturer le travail de groupe. Donc, justement, voilà, c'était peut-être un geste prémonitoire. Voilà. Donc, vous étiez en train de cliquer sur le bouton parce que nous avons invité tout le monde à nous rejoindre. Voilà, vous voyez que tout le monde arrive.
Ah, d'accord, OK.
Voilà, merci en tout cas de votre contribution à la discussion. Voilà. Merci beaucoup. Voilà, je vois que tout le monde est de retour. Merci pour vos discussions. Ce n'est pas toujours facile d'utiliser un outil comme celui qu'on a proposé, mais je vois que vous avez fait de votre mieux pour partager. Et donc, je donne la parole à Alison et Sanam pour peut-être réfléchir, regarder un petit peu les éléments qui ressortent et nous proposer aussi une réflexion par rapport à ce qui ressort de quelques
Thank you very
éléments.
much, and thank you for participating. So, and I can see that more and more is being added, and I think that's the nice thing about this tool is that we can add as you know, even now when we're back in the plenary. And I think that what is helpful here is that this then becomes a document that we can work with and reach out to you after this webinar to see what supports you need and whether GFF's in a position to be part of that support. So it's been really helpful to see, as you see, we've put the countries that are represented in each group on the top of the Padlet, on top of each group name, the country names, and then you can see that each group has identified the readiness level, the enablers and constraints, and then some of the supports required. And I think what is striking to me, and obviously catching up on the fly a little bit here, is that you know, there is generally an appetite, that the recognition that this is a priority is, you know, that's not the issue. The challenges are around what's required to actually make this happen. And it seems that across the different settings that there are some themes emerging here. One is around having that, if I think back to Sonia's presentation where she said, you know, it was really important to have that ministerial level letter or authority, so that both the government support and then the policy, and then, you know, quite a few of the settings have said, you know, some of the protocols, some of the infrastructure equipment, although in some settings that is available. And it looks like examples that in, I think it was Guinea has, you know, some of the NGOs and UNICEF, JPIGO and UNICEF supporting both equipment and training and protocols. Other countries, it's very limited to the capital city or to private facilities, and that there's quite a theme around some of the system issues. And I think this is really helpful to reflect on, is that, you know, just having equipment and people and a space does not make magic. It doesn't provide the care that there's a lot of system thinking around what does this mean for how the labour and ward functions, how do we support that process. So I think that's really helpful reflection to base on, to think about all of the unintended consequences of making any change in any part of the health system. It's no different for small and sick newborn care. I want to, at this stage, and hopefully Dr. Chilani and Michael Mateka-Fisher have had a chance to have a quick look at this and ask them to provide some reflection on the responses here and their experience. As you would remember, Dr. Chilani and Dr. Arya were running the large program on immediate Kangaroo Mother Care in India. And Michael Mutekefesha runs the Innovations program. And you know, a lot of this work is a little bit innovative and has supports two programs that are involved in care of the small and sick newborn in Ethiopia and in Kenya. So Michael, I might ask you first to reflect on the experiences in the programs that you've been supporting and how they align with this, or whether you've got other insights to share with us. Thanks, Michael.
Sure. Thanks, Alison. And it's just to correct really quickly, it's actually Ethiopia and Tanzania, not Kenya. But
my apologies.
No, it's
Sorry.
okay. So for background for everyone, one of the work streams in the innovations program at the GFF is a program called the Innovation to Scale Initiative in partnership with UNICEF. And we're supporting 2 innovations that are specific to neonatal and maternal care. In Ethiopia, we're working on scaling up the Saving Little Lives bundle and with partnership with Addis Ababa University, Mekelle University, and Emory University. And the goal in Ethiopia is to bring effective KFC scaled up to 290 hospitals and reduce neonatal mortality by 35% at the population level. So I'm looking at the group 5 challenges, and there are a few that resonate to me. Implementation research is needed to demonstrate evidence, I think, is a very prescient and pressing problem. And the Innovation to Scale initiative is working to generate that implementation research and evidence at scale. Government buy-in has also been a challenge in Ethiopia, especially considering and in light of the shifting priorities around COVID. And I would also add another one that I don't see listed, and apologies if it was discussed, but one of the challenges we're facing in Ethiopia is that our main target is a population level reduction in neonatal mortality. And that requires strong linkages between community level workers to mobilize mothers to give birth in the facilities that are equipped for effective KMC and iKMC. And that's a disconnect that we're having a little bit of, we've recognized early and are having a little bit of difficulty in overcoming, and something that we hope to address through the program. So I think that the linkages to community workers and social mobilization is maybe the next phase of implementing this after setting up the equipment, after building the capacity building and setting up the facilities, but I think an important one if we want to see the really high population level impacts we're all aiming to achieve. In Tanzania, we're implementing what's called the Safer Birth Bundle, which is a combination of a variety of digital tools such as fetal heart rate monitors, resuscitation monitors, and what's called neonatally, which is a digital live newborn resuscitation trainer that can duplicate various emergency situations right after birth. We're scaling up this bundle with a combination of high dose, low frequency training that has digital tools to enable the successful training in 30 hospitals in Tanzania. And that has been, we're still early days in the implementation of that, and we're in the process of orienting our government partners around that program and some of the early results to receive their buy-in. And so I do think that we need to see that there's the potential as this program scales to address some of the capacity building needs that are outlined in some of your comments from the group work. So I've spoken long enough. Feel free to ask me any questions, but I'm moving on.
Thank you. Dr. Chilani.
Yeah. Thanks, Alison, for the opportunity. And of course, I could read the English ones and had the discussion. So just quickly, I want to touch a few points because I feel that KMC should not be looked as just one vertical program. And we should see the small and sick babies care as a package care, and where KMC is just one part. And we should, another thing which we should look into this is the concept of zero separation. And once I think the WHO comes out with the revised guidelines and the toolkit, which we are, I think globally also we are working on the toolkit. So once these guidelines are placed, I'm sure each government is going to revise their guidelines. And then I feel it is important to develop few model units where we should actually try to do the implementation research. Which we have done in the research mode, is it possible to do it in the implementation? So these units is going to give us the data as well as going to develop the role model. And then of course there would be more states would come, and initially there would be the support of the partner agencies to the government, because I remember in India UNICEF came in a big way to support initially the SNCUs or special newborn care units. And now in India there are more than 900 units, so almost more than 1 or 2 special care newborn units in each districts. And it was a phenomenal thing which we could do. So as initially you also mentioned, it's not the equipment, but it is the care of touch which is important along with the equipment. And equipment, I feel once the mother is inside, hardly there will be use of the radiant warmers. The warmth would be provided by her, and more she would be a caregiver than purely a visitor. Over.
Thanks very much. And yeah, that's a really helpful reflection. I mean, my takeaways are very much around that if the starting point is not separating the mother and baby, then the implications for that in how we set up care becomes much clearer, and the sort of immediate KMC makes sense, aside from the fact that the clinical evidence for its life-saving capacity is very profound. But I think the other takeaway that I have learned is that if we discharge babies from special care neonatal units straight home, we are likely just to set them up for adverse outcomes in the community. And so that idea of a step-down unit or some transition space that needs to be considered is also really important. Sonam, did you want to provide any of your reflections as you saw the Padlet and from today's session?
It's been great, thank you. I'm thinking about the experience of the mother and making sure that, we're thinking also about her experience being, bedbound, having a baby tied to her, potentially needing to go take care of herself, just having given birth, and, making sure that we don't lose sight of the importance of having her comfortable and having a positive experience. And just on that point, also, I just want to highlight that there are potential benefits for mothers also. Breastfeeding is associated with fewer chronic diseases in the long run, and so I just want to highlight the mom and the mom baby, and make sure that we're keeping both of those in mind, and hoping that as more research develops, potentially implementation research, that we really do justice to both in the pair. Thanks.
You're on mute, Alison.
Sorry, thank you. We've got to the last 5 minutes. I want to just perhaps share some of the next steps before we finish. Sorry, I've gone ahead of myself. And just give you a few teasers of what's coming up. There's things happening this month, next month, and next year that all relate to this really important topic. Many of you may have heard of Nest 360. It's a large program that involves multiple institutes in mainly sub-Saharan Africa, and works in 4 countries, and I hope I get the countries right, which is Nigeria, Kenya, Tanzania, and Malawi. And they are doing a large program to test out what it takes to provide CPAP, that sort of next level of care for the small and sick newborn. And one of the parts of the program, there's a range of training videos, there's equipment bundles, there's biomedical engineer training, there's health worker training, there's a lot of pieces to this quite large program, but they have developed an implementation toolkit, which will be launched on the 17th of November. And this looks at all of the health system building blocks and what that means for the provision of newborn care. Next month, as Dr. Chelani mentioned, WHO is hosting a consultation meeting on December 1 and 2. That's to share country experiences. And I didn't bold India because currently GFF isn't supporting that. But I realized I should have been a little bit more universal and inclusive. But they're looking at sharing country experiences, and 37 high burden countries will be invited to participate in this consultation with a view to taking the standards for improving care and turning that into the implementation guidance. So a parallel and supportive complementary program to that of Nest 360. And finally, something that the GFF is undertaking over the next year is to look at developing a costing tool. Sometimes we don't really understand all of the costs involved in introducing a program that may not have, might have been very early and nascent before this. So the idea is to get some case studies of where, like Haryana State, like one of the NEST countries, to see what components are required, but not only what are the inputs required, but how do you cost the strategies that are required to change the way people think about care of mothers and babies? How do you change, how do you cost changes in thinking around who goes into a special care unit or where it is set up? So looking at some of the strategies, and with the view, if we can develop a user-friendly costing tool to support countries to model requirements for the care. So just wanted to flag that this is not just a standalone effort, but is part of a program of work, and we're linked with other players. And we will also take what has been written in the Padlet and try and see where we can provide additional support where necessary. So that's all from me, and I'll just hand back over to Lewis to close us out. Thank you.
All right, thank you very much, Alison. And I know we are at the top of the hour, so I'll be really, really brief. And it's mostly to thank you all very much. Of course, a special thanks to Alison and Sanam. I think you've been restless in bringing this topic to the agenda in this format. Very much what the exercise you're doing now, Alison, trying to put this in a wider frame, an intentional support to the countries in this arena. And we can't thank you enough for bringing that up again and again. A big thank as well, of course, to Pascal and the team of the GFF, the Knowledge and Learning, for setting up this webinar. But mostly, and this is the message I'd like to send, is a big thank you to all of you, the participants. We keep hearing from the countries how important it is for you, that's what we hear, to learn from one another, to learn from practices and experiences and perspectives from other countries. And that requires, let's face it, that requires quite a specific attitude from the participants, an attitude of generosity, of humble listening to other experiences, to really contribute and collaborate in the smaller groups. And I think you have demonstrated that extraordinarily today. I've learned a lot as well myself, and I wanted to thank you all really very much. We will possibly be meeting again in a setting like this. I know Pascal has a few words before we really wrap up, and I won't take more of your time. Thank you very much.
No words from my side. I was just adding that the slides that Alison shared were a little bit hard to read, so I just pasted the slides here. But then I'd like to thank everyone, thank the interpreters, and thank you all for your contribution. As you know, if you have any questions, anything you need from our side, in particular from Alison, Sanam, and all the contributors, do not hesitate to contact us. Et donc voilà, je voudrais remercier. Et je vous souhaite une bonne après-midi, une bonne journée, bonne matinée à tout le monde. Thank you so much. If you want to open your cameras as a last moment to say hello so we can see the faces. Voilà, thank you Aïssatou. Merci à Sina.
Thank you, Pascal.
Merci Amat,
Well
merci.
done. Thank you.
Merci Amat du
Yeah,
commentaire.
so,
Solange,
exactly. Please share
merci.
the recording so I can
Thank
share
you,
with other South
Marianne,
Asian
Costin.
colleagues.
Merci.
Au revoir.
Bimbo, thank you, and see you
Thank
very
you.
soon at another event.
Thank you
Allez,
very much.
Bye. Thank you, everyone. Merci.
Merci, merci.
Keep
Merci,
this
faces.
opportunité.
Merci, au
C'était
revoir à
utile.
tous.
Merci.
Thank you,
Avec
everyone.
plaisir,
Bye.
Costin.
Au revoir.
Merci, au revoir.
Ibrahima.
Merci, au revoir.
J'utilise vos prénoms, mais vous êtes sûrement docteur quelque chose. Donc,
Au revoir à tous.
au revoir, bonne journée.
Au revoir.
Bye, everyone.